Well, in the mandible, a U-shaped bone with a joint at either end, any blow to the mandible typically transmits force to the point of impact and a point most distal from that. So what we commonly see, if a patient gets in a bar fight, gets punched in the jaw, most people are right-handed. If they're facing each other, the patient will have a left symphysis fracture and a right body angle or subcondylar fracture. So almost always there's two fractures. If you fall on your chin, hit your chin directly, you're most likely to get bilateral subcondylar fractures, distant from the point of impact. Occasionally a symphysis fracture, but since that's the strongest part of the jaw, oftentimes it'll be transmitted to the weakest part, which is the subcondylar area. So as we look at these types of fractures, anterior to the bicuspid, so cuspid and the lower incisors, about a fifth of fractures, 22%. Angle fractures are seen in about a quarter of mandible fractures. Condylar or subcondylar, so that means the condylar head or the condylar neck, almost 30% of fractures. And the mandibular body, about 16% of fractures. How do you know if a patient has a fracture? What if you don't have radiographs to look at? Well, the first thing you should do is look at the patient, even before you get your radiographs, because that will guide the type of imaging that you may want to obtain. So patients come in, they will often tell you that their bite is off, so they have a malocclusion. There usually is bleeding at the site of a fracture. So you may actually see bleeding or at least bruising at the area of a fracture. So when the bones break, bones have blood supply internally, and that blood leaks into the surrounding tissues. Occasionally, if the fracture is open, you'll see it bleeding from the fracture site, but more commonly, you'll just see bruising or ecchymosis over the area. If the patient comes in immediately after a fracture, there may not be a lot of swelling, but if the patient comes in a day or two later, sometimes a week later, you may see significant swelling at the site of fracture. They have pain where the fracture is. They may have pain in other areas as well, but there will be significant pain right at the fracture site. It's called point tenderness. So if you touch where the fracture site is, patients typically will withdraw and say that it hurts. You may be able to feel, if there's not a lot of swelling over the fracture site, you may be able to feel the discrepancy in the bone. So what we call a step, where the one side of the fracture is at a position different from the opposite side of the fracture. And you can actually detect that by feeling. In the mandible and in the midface, patients may complain of anesthesia of an area or at least paresthesia, that is an altered sensation. So any fracture that involves displacement of the inferior alveolar nerve, patients are likely to have a numb lip or chin on the side where the fracture is. In the midface, if they have orbital fractures, or they get hit in an area where the infraorbital nerve exits the face, they may have numbness of their cheeks, their side of their nose, or their upper lip even. And of course, functional disturbances are associated with these fractures. Patients may not be able to open because of displaced bony segments, or they may not be able to close completely because of displaced bony segments. They won't be able to chew, or it will hurt when they chew, so they will have difficulty eating. So when we treat these patients, if our goal is to put the teeth together so that we reestablish the occlusion, it's hard to do that with general anesthesia and an endotracheal tube. So there are some other options to do this. The reason that we can't put a tube through the nose into the airway like we would normally do if we're doing osteotomies or many other procedures where we're working intraorally, is that if you have fractures of the midface, putting a breathing tube through the nose is contraindicated because it can be directed through the fracture lines intracranially, all right? And there are instances where that has occurred, and these are well recognized in the literature. So two options if we have to deal with midface and mandible fractures where we need to put teeth together. One illustrated on the right side here is a tracheotomy, where we actually cut into the trachea and place a breathing tube right into the airway through that opening. The other, on the left side of the screen here, is something called a submental intubation. And this uses a special armored tube so that the tube doesn't kink. But the patient is intubated through the mouth in a normal fashion, as with any other type of general anesthetic. And then we make an incision in the anterior part of the mandible, below the chin, take the end of the tube off, put an instrument through that incision, grab the tube, pull it through the skin, and then suture it to place. And that's exactly what you see here. This is one of my patients from a few years back where we had to do this. It's not used often, but it will allow us to put the teeth together and reestablish the occlusion. So let's look at the clinical signs that you can see on fracture patients. So here's a patient that exhibits what we call a bony step. Okay, so you see the molar is in contact with the upper bicuspids, but the lower bicuspid is not in contact with anything. You also see there's a gingival tear. That should imply to you that this fracture involves the periodontal ligament and therefore is an open fracture. You got a gingival tear that communicates with the fracture, that makes it open, goes through. That this fracture involves the periodontal ligament and therefore is an open fracture. You got a gingival tear that communicates with the fracture, that makes it open, goes through periodontal ligament space. Even though you can't see the radiograph, you know that will be true. You should also be aware that this was an orthodontic patient. You see there's only one bicuspid up and down on either side, so this patient probably had a pretty good occlusion, and we should be able to reestablish that occlusion. Now, these types of fractures don't always have to be open. We can manipulate those segments back together and hold them in that position for the patient to heal. So this illustrates our standard arch bar. These are stainless steel things with hooks incorporated into them, as you can see here. And you see that there's wires holding these bars against the teeth. And we have rubber bands, in this case, holding the jaw together. In many cases, we will wire the anterior segments as well. In fact, I am a fan of that because it gives you better ability to generate forces to get the fractures reduced. But not every surgeon will use wires in the anterior region. The radiograph on the right, you can see the fracture between the bicuspid and the first molar tooth. And it looks like there's two fracture lines, so you might think that's a comminuted fracture, but it's actually not in this case. And the reason it's not is that the mandible has thickness. And the fracture never goes, or almost never goes, directly through the bone so that you only have one fracture line. One of those fracture lines is actually the buccal cortex, the other is the lingual cortex. So it's sort of a sagittal type fracture that you can see two fracture lines, but there's really only one fracture in this case. These arch bars are newer, and these are a lot safer for the surgeon than the old type. So what you saw before was wires around the teeth holding the arch bars in place. So that's great and it works, but there's not an oral surgeon in the world who hasn't been stabbed repeatedly by sharp wire edges as they're passed between the teeth. So in light of today's infectious diseases, including HIV and hepatitis and all those kinds of things, we're looking for safer ways to put the